everyone. So now we had a very interesting session. So now we are coming on to the next session, which is about the recent advances in orthopedic oncology. And this ortho-onco session is now a routine in AMC master's course, and for last many years we have been doing this session. So hopefully we'll keep and make it enjoyable and interactive. So because now we have this session of this talk, and after that we have a very interesting panel discussion. So I request you all to stay so that we can have a good discussion. So this is where I work, Max Hospitals in Delhi, where we have I had two units where both are comprehensive cancer centers. Primarily, as an orthopedic oncologist, we deal with bone tumors, sarcomas, soft tissue tumors, soft tissue sarcomas, metastatic bone disease, pathological fractures. 15 to 20% cases also comes to me with complex bone and joint reconstructions, sometimes after large bone defect, after gunshot injuries or revision, complex revision arthroplasty. We also do quite a good number of interventional procedures where radiofrequency ablation or percutaneous techniques are utilized in the treatment of bone tumors. Now, talking about the malignant tumors, my topic is from mechanical prosthesis to biological reconstructions. So we start with the mechanical ones first, that traditionally what techniques or modules we are utilizing for limb saving surgery. So like this type of scenario where you see osteosarcoma of proximal tibia, where we remove the tumor with wide margins. We take 2 to 3 centimeters of margin, the bony margins and soft tissue margins. And once we resect this, so there are three important components. Like you can see, first part is removal of the tumor with wide margins. Second, once there is defect, we need to reconstruct that bone defect with whatever you choose, megaprosthesis or biological reconstruction with bone grafts. And then equally important is to reconstruct the soft tissues. The first part, which involves resection of the tumor with wide margins, is essential and very critical, because this is something which gives you a good oncological outcomes. If this process is compromised, you're going to see the patient with progression of tumor, progression of malignancy, metastasis, or even death. The other two parts, reconstruction, is important to get a good functional outcomes. So all these three components are essential if you want to get a good oncological and functional outcomes in the treatment of bone tumors. Now this is just a small video. Many of you might have seen also how ideally we should remove a sarcoma. So this was a recurrent tumor of upper tibia with a pathological fracture. And when we remove such tumors, it should be removed in a way that the tumor is never exposed. You are beyond the capsule. The conventional way in routine orthopedics, how we deal, we just go on the capsule, remove it. But in this situation, even with the pathological fractures, you see, the biopsy scar is completely en bloc removed. If I move the tumor, not a drop of blood or hematoma from the pathological fracture comes out, because it is surrounded by a normal tissue. So this wide margin, the margin is not the tumor surface or tumor capsule, but it is the normal tissue all around the tumor part. So when we operate like this, then only you get a good oncological clearance, and that's how your recurrence rates are minimal to less than 5% in these cases. Now we reconstruct this. This is a modular prosthesis, and you do, like in this upper tibia case, we do flap reconstruction, medial gastroc flap. This is not just to cover the implant, which is subcutaneous, but since there is loss of extensor apparatus, we need to give function. So this repairs and reconstruct a new extensor apparatus in this scenario. And this is like most of the patients, they start full weight bearing walking with prosthesis from the first post-operative day. Some other advancements have been the total bone replacements, like you see in this case. The tumors was reaching quite high up to the lesser trochanter following a pathological fracture. And here we remove the entire bone right from hip joint to the knee joint. You can see the vessels there. You can see the vessels and the nerve there, which is all removed. we need to be very careful when we do the dissection. Apart from protecting the neurovascular bundle, we need to keep a safe margin. And this is how it looks like. So these are modular implants. This is the specimen. And since the tumor was up to the lesser trochanter on the medial aspect, I osteotomized the trochanter along the gluteal attachments, and it is reattached over the prosthesis so that the patients have good outcomes. Now this is just a video to show you what the modularity really means. So if you see this implant component, it has different components. The upper part is the trochanteric part. You have the head, comes in different sizes. These are called spacers or the resection piece. And the lower part, what you see is the condyle, the femoral condyle. So certain components have a fixed length, like your trochanter. In this case, probably the company which I use has 80 mm. Again, this 80 mm. And in between, whatever length you want to make out, whether you want to create 20 centimeter, 30 centimeter, 31 centimeter, it has increments in 10 millimeter. And you can reconstruct any length of implant. So if you want to make a small implant, just one piece. If you want to make bigger implants, you can add similar resection pieces in between. So this is just the functional video. So this is just immediately, usually 4th or 5th day in the ward, patient is there. And this is after 3 years when patient is an independent ambulator. This needs a good rehabilitation protocol. Just before, like Dr. Porter was talking about the expandable implants, especially in pediatric patients, those who are less than 12 years of age, we prefer to use these expandable implants. So this young girl, 8-year-old with osteosarcoma with pathological fracture, we start with chemotherapy first so that the bone unites, and then we plan for an expandable implant. So if you see here, so this is one of those where we use a screw mechanism. So this is the intraoperative picture when we have resected, reconstructed. This is the part which will expand over the time. So this was just immediate post-operative. On the X-ray, you can see this zone where it expands. Now this is the follow-up. You can see patient has some limp. That's because of the shortening. And we do this on the OPD basis. Now this is the follow-up. You can see the function. So a lot of advancements have come in the field of technology and prosthesis and implants where we can get good functional outcomes. Now coming to the recent advances and moving on towards the biological reconstructions. A broad idea, when we have to sacrifice the joint, we need to use some implants or prosthesis, especially in lower limbs, because it's a weight-bearing area. But once the tumor is metadiaphyseal, like this case, with a young girl with Ewing sarcoma of the distal tibia, we have prosthesis, but many a times these cases have to undergo amputation because the biological reconstructions techniques, if they are not known to the surgeons. So in this case, we could see that the growth plate was free, and we had the upper extent, we could take any margin. So reimplantation of the cancerous bone is something which we have been using for last 15, 20 years, where we remove the tumor out of the body with wide margins, and then we radiate it while the patient is anesthetized. We send it for radiation, and then we reimplant it back. So this is our radiation oncology colleague in the operation theater. And then once it has been radiated, it's brought back and put into its place. But as orthopedic surgeon, I know all of you must be thinking, if a small piece of traumatic bone comes out of the body, we think twice before fixing it in. So how much such a big segment you take out, it roams around everywhere and comes back and you reimplant. So of course it has 20% risk of infection, later on necrosis, pathological fractures. So to counteract these problems, we had a thought, like, can we do anything where we can sterilize the bone while it is still attached inside the body? So this is a new technique which is called cryotherapy, pedicled cryotherapy. So here this young girl had sarcoma of the distal tibia, where we could have done the same procedure, resected this, radiated and put it back, but here we used a different technique. I started using this technique since 2017. It was one of the first cases we did in India. So you can see here we did a single osteotomy, not two sides. We dissect out the vessels, the nerve, everything is protected, and then we dip it in liquid nitrogen. Liquid nitrogen has a boiling temperature of minus 190 degrees centigrade. So it can kill all the cells, and this is the video that you see. So we marked it with a margin so that we dip it entirely. It's very, very cold. You cannot keep your finger inside for more than 2-3 seconds. With that, your fingers will freeze completely. So this will kill all the cancer cells, and along with that, the normal cells also. But since it is osteotomized only at one end, the other end provides it the vascularity which is required. So we implant it back. It's again put back in the position. You don't need any prosthesis, simple plate. And now you can see the osteotomy site, how it started healing. This is immediate. This is around 2 to 3 months. And this is around 5 to 6 months. So this patient was from Patna only and from Mahavir Cancer Sansthan, where we operated. And you can see her functions. She's back to her routine. Now, pelvic reconstruction with biological reconstruction. So we had very interesting case series shown by Dr. Porter, where we used very good implants. Personally, my preference has been biological reconstructions because majority of the patients that we see are like this, a large Ewing sarcoma involving part of the sacrum, and you can see up to the acetabulum is involved. So depending upon which part of the pelvis you remove, you divide them into type 1, type 2, type 3 hemipelvectomy, and when you resect the part of the sacrum, it's type 4. So we have advances. We make these 3D printed implants and zigs to give us a precise margin intraoperatively. We also have computer navigation to identify our cuts and make the cuts with precision. We remove the tumor entirely with wide margins, and this is what it is afterwards. You see the one of the cut was through the sacrum, the other was below the acetabulum, and this hip is reattached along with the mesh. So it's a polypropylene mesh that we use in hernia repair or in general surgery. So this is, patient also received chemotherapy, neoadjuvant, adjuvant, and radiation, and this is his 4-year follow-up. I just want to show you his functional outcomes. So one of my arthroplasty friend, he saw this and he said, now what is the need for a hip replacement if without any hip in a pelvis, if the patient can walk like this, why we need to do hip replacements? But it's not so. Every case and indication is different. So again, coming to pediatric population, this was a 2-year-old girl, a boy, with osteosarcoma of the distal femur. Now at this age, even the mechanical prosthesis, it's very risky. At 2 year, people don't use even expandable. It requires so revision that ultimately ends up with amputation. So this was reaching up to the growth plate devices. So what can we do now in this case, whether to save the limb? Significant limb length discrepancy chances are there. So in this situation, we wanted to distract this a little bit so that we get a margin over the growth plate. So we used Canadell's technique where we distracted it. We could gain some length to have a good margin. And then we resected this tumor completely through the physis and then upper margin. We radiated it, and along with that, we used fibula, vascularized fibula with its growth plate. So this is what you see. This is the ECRT fragment, and in between you see the fibula which is placed. It's called Kapana technique with the neurovascular bundle which is reattached. So you can see here now this is the part of the fibula. This is the radiated bone which acts as a scaffold. Finally, the fibula remodels as femur over the time. So this is a 15-month follow-up for this boy. I operated him last January in 2023. He was just 2-year-old. Now he's almost 3.5. And so far it's good, but I really don't know how the future is going to be. But these are the indications where we have pushed the limits of physiological boundaries and tried to achieve limb-saving surgery in sarcoma cases. So quickly to summarize, sarcomas requires a multidisciplinary approach with surgery, chemo, radiation therapy. And this is based on the histology. And contrary to the belief that these sarcomas have a very poor outcomes, it's not so. If treated at the right center with specialized sarcoma centers with chemo and multidisciplinary management, these have very good survival outcomes and very good limb-saving surgery outcomes. So almost more than 95% of the cases, we are able to do limb-saving surgeries in bone cancer. Then there are different modes of reconstructions I have shown, biological or mechanical, which we can use based on the type of tumor, based on the surgeon's expertise, facility, cost, other issues. But remember that limb saving is possible in majority of these cases. So thank you very much.
Dr. Vivek, mesmerizing practically the word should be. It seems that the patient must be witnessing God in you. But it's really good. All the videos and the jumping, I mean the dance, it's very, very, very effective. And definitely the patient has a confidence. That's why they're coming up with all recent surgeries like this. Only point I wanted to ask is, in the one you took out the bone, radiated and put it back, it was a non-vascularized bone. So the chances of rejection, as you told, it won't be a vascularized flap. So the chances of rejection is quite high compared to the one which you detached from one part to the other. And the other thing is, the bone is easy to resect, but what about the soft tissue component? You must be facing a severe challenge with soft tissue reconstruction, or probably you are seeking a plastic help in that. What is your take?
Yes, sir. So that's true, because every case we need to do some reconstruction, like I said, both in bone and soft tissues. So I don't need plastic reconstruction in all these cases, whichever I have shown. So all these cases were reconstructed, even gastroc flap or whatever, I do it myself with our training going on. Certain scenarios where there is a large skin defect, then we may need a plastic reconstruction. For free vascularized fibula, we need plastic reconstruction help in those scenarios. So otherwise, majority we do it ourselves.
Dr. Vivek, I would like to ask you, arthroplasty versus, of course, prosthesis. How do you case select? And the second point is that would you allow arthroplasty to be done in your metastatic patients as well for metastatic bone disease?
So, ma'am, what I understand is arthroplasty, you mean routine joint replacements or the same?
The 3D arthroplasty that you have. Yeah.
So basically when the ends of the bone are involved and when we dissect the tumor, we need to have a megaprosthesis or tumor prosthesis, because if we do biological reconstructions like this with pedicle cryo or ECRT, that part will get necrosed. It will not be able, over the time it will decompose. It depends upon weight bearing and non-weight bearing bone also. Like for proximal humerus, I have used pedicle cryotherapy. But in lower limbs, some cases are going on, but we need to see long-term results, whether biological will sustain or not for the long time. So far, we use prosthesis in cases which involves joints. But in between, if there is any metadiaphyseal tumor, I prefer to use biological reconstructions. So that is how I choose my patient.
So if I have just to make a comment upon, and you are a part of my team, so I'll say that the patient when comes to you has to be counseled thoroughly, because I'm an opening batsman in your situation for osteosarcomas or Ewing sarcomas. I start with chemotherapies, and to my follow-up, I think 30 to 40% of the patient, when they have such a good response to neoadjuvant therapy, they sit back. And when they come back, they are in a very, very disgusting situation where we need to restart therapy or just to subject to a surgeon. So the very first day, I think we need a counselor to make them explain that we are a team. You just cannot run away, skip away with one treatment, and that just ultimately landed up into pulmonary metastasis, or very adverse of the situations that I do see in my day-to-day practice. So things have to be made very clearly understood, built to the patient, to the attendants, and everywhere when we need such a good result to come up. This is just a comment that I wanted to make.
No, ma'am, absolutely, totally agree with you. Because if we look at all the cancers, the highest abandonment rate in treatment is with these bone sarcomas. Why? Because if even if we have counseled about medical management, but when they hear that they need to undergo amputation, sometimes they run away in between for the fear of losing limb. They don't look at the broader picture that not taking proper treatment, ultimately they may not survive. So a proper counseling on the first visit, I think with the complete team, multidisciplinary management, will definitely improve the outcomes. So I think we'll quickly move on to the next session. Sorry to keep showing my face on the stage, but I don't have an option. You also don't have an option. You have to watch this. So this is going to be a panel discussion. And we have a very good panelist with us already. You have listened to their words of wisdom. But the questions are not just for the panelists. I mean, this is an open forum. Please, anybody, because I know the topic I have chosen is giant cell tumor. And this is, I think, majority of them are treated at local level by orthopedic surgeons. And there is nothing like one way only, that this is the correct way. So there are many options which are possible. So I want everybody to interact. Whatever you feel in this situation, you give your opinion and inputs on that. And apart from that, we have prominent panel faculty as well. So just to quickly give you some epidemiological inputs about giant cell tumors. So it's a locally aggressive tumor where we see metastasis also to the lungs, especially up to 2.5 to 3% or 5%, some reports say. It is, currently, it is recorded that it's due to a mutation, which is H3F3A mutations. Primarily, we see them in adult skeleton, mature skeleton. So anytime if you see a lesion somewhere in the premature skeleton, don't jump on to treat it like a giant cell tumor. Always look what is the age of the patient. The literature says the recurrence rates as high as up to 50%. That was the old literature. But the recent ones with complete, use of extended curettage and different treatment modalities, we have seen recurrence rates as low as 5 to 6% to 10%. So this is just what I discussed. The etiology is because of the mutations, which leads to development of these tumors. Quickly, a few words about the bone homeostasis. We all know, we are reading since childhood, osteoblast and osteoclast, and we think the world moves between these two in our bones. But there is a lot more development and understanding how actually the bone turnover takes place. So how the premature osteoclast becomes mature osteoclast when there is something, they have a receptor called RANK, receptor activator for nuclear factor kappa beta, on which RANK ligand attaches and converts it. Why this is important? Because different drugs that you use in your practice for osteoporosis or for like denosumab or parathyroid hormone analog, all these are based on this mechanism. So it's important that as orthopedic surgeons, we must be aware of the pathways which leads to osteoclast mechanism and their inhibitions. So broadly, that was all. Now let us start with this. Do we have residents here? Residents? Even if there is somebody, they will not raise their hands, right? Okay. So, Himanshu, so read the X-ray, please. What do you think it is? Whatever you see. Yeah. Yes, you only, Himanshu.
So there is no X-ray, sir, actually.
Oh, so you're lucky. My previous slides were playing on or no? Or I was just talking? I was just talking. Okay, I thought here it was moving on. Fine, it's okay. Now we start with the panel now. So what do you see here? Just tell me.
Sir, this is the X-ray of knee joint showing distal part of femur and the proximal part of tibia with lytic lesion on the lateral femoral condyle with
I think
with
there's
the
some wire is loose, I think. Yeah.
the lytic lesion on the side of lateral side of femur with the eccentric type of lytic lesion.
Yeah, you're right.
The
Anything else?
margins of the lesion is the demarcation is present and
So you can see well-defined margins. We can
well-defined
mark-
margin. Yes, sir.
Right. Okay. Anything about?
There is no any involvement of soft tissue. It seems no involvement of soft tissue.
Okay.
And,
Periosteal reaction?
yes, sir. There is a periosteal reaction is seen. It's,
Fine. Overall, what do you think it is?
so it must be a benign lesion.
Very good.
Uh,
So rather than jumping on the histological diagnosis that it is a GCT, you need to have a broad overview. That overall picture says that it's something a benign locally aggressive lesion. Probably you can see there is some cortical breach there, or there is some microfracture lines that is seen. So I know I can see much more because this is my case and I have gone through again and again. So it's okay. Good. Very good.
Thank you, sir.
So quickly for all the residents, I'll summarize this picture. Whenever you see an X-ray like this, start with whether it is mature or immature skeleton. Where is the lesion exactly? So you see it is epiphyseal and reaching up to metaphysis. What type of lesion it is? Is it purely lytic, lytic sclerotic? Any matrix? Matrix means the ground substance that you see inside. So when we say a purely lytic lesion, that means there is no matrix. But when you say that there is some calcification or ossification, that depends upon, that will guide you towards the histology. Then you need to comment about the zone of transition, means how the abnormal part of the bone is merging with the normal bone. Can you draw a line around it? That means narrow. If not, it is diffusely merging. It's a broad. Then you need to comment about any pathological fractures, periosteal reaction, soft tissue component. So, Akash, if you have an X-ray like this, now what will you do further? You will do the biopsy directly, or you will plan for surgery?
Sir, I'd like to take an MRI first to see the soft tissue involvement.
Fantastic guy. So, you know the protocol that we get the MRI. After this, we got the MRI. Now, do you want to, this looks like a good homogeneous zone. Yeah, let's say heterogeneous also. Now, do you want to operate? This looks like a benign tumor, right? Based on X-ray.
Yes.
So everybody agrees. It looks like a benign tumor. So should we go ahead and plan for treatment, curettage, resection? What do you want to do?
Excisional biopsies.
Okay, we have some hands. Yes. Excision biopsy. Okay. It's fine. We are involving the audience also in between.
True cut biopsy, yes, and we should also screen for other lesions, something like skip lesions or similar lesions in the other
How do we screen that?
PET scan.
Okay, PET scan. Okay, some comments from behind.
MRI of one joint above and one below.
So you want to ask MRI knee and MRI hip?
Yes, sir.
Okay. So let me just correct it how we should order an MRI. For MRI, you should write contrast MRI of the knee with full length of femur. That is how it should be advised, not separate hip and knee, because we need to see the compartment where the tumor is. So if it is in this proximal tibia, we'll say contrast MRI knee with tibia full length. This is how, I think this is very important when you are writing prescriptions. One point you said excision biopsy. So yesterday I had shown excision biopsy means you remove the entire tumor. So without the diagnosis, how are you planning excision biopsy? I mean, are you resecting the joint? So that's why we do a core biopsy first to identify the diagnosis, and then we plan depending upon what it is. One point you said about staging. So staging to find where is the extent of the tumor gone, in the local same compartment or in other parts of the body. Usually we do the staging secondarily once you have the diagnosis. Many a times, you know, the other differentials that we can see can be many. Like if we see a lesion like this, it can be benign. And sir, you want to comment anything, Dr. Porter, on the differentials?
You're doing very, very well, Dr. Verma. I mean, you haven't got a diagnosis. Yesterday's lecture, nobody will blame you for doing a biopsy.
Can I add a point?
Yes, sir.
Apart from the radiological, any other investigation would you like to involve here? It's important here because it's a lytic lesion and calcium, calcitonin, those things have to be considered.
Very, very, very important point. So anybody who wants to comment about blood investigations to see in these cases? A very simple investigation. You may not need to ask it separately. It's already in the profile. Anyone? आगे आ जाओ कोई बात नहीं.
Sir, PTH, I would like to go for PTH for suspecting a brown
Okay,
tumor.
PTH, what are you suspecting?
Any brown tumor, sir?
So before you ask for PTH, already see when a patient comes to you for the
ALP,
first time,
sir, I would like
alkaline
alkaline,
phosphatase.
ALP,
So
sir,
when
yes.
you ask for CBC, liver or kidney function as a routine workup when you see a patient, if the alkaline phosphatase is raised, that will raise the suspicion of a Brown's tumor,
Yes, sir.
right? What will happen to the calcium in those situations? It's raised,
Yes.
right? Okay, good. So that is one very important point that will give you a clue, especially in isolated bone lesions like this.
One more point, can I add here?
Yes, sir.
In the previous X-ray practically, you can see the edges looks like advancing edge. Although it's well demarcated, but it looks like it's advancing.
Right.
That raises a point of conversion to sarcoma. That 1 to 5%, whatever you call it, that should come in mind.
So that is the reason why we should always do a biopsy. Even though your radiological imaging may be suggestive of a benign lesion, but in this type of situations, like a lesion like this, you can see the differentials. It can be a giant cell tumor, it can be an aneurysmal bone cyst, it can be a telangiectatic osteosarcoma, it can be clear cell chondrosarcoma, it may even be a brown tumors of hyperparathyroidism. And all of them have different treatment, right? So it's very important that we always diagnose and then biopsy it. So fine, biopsy was done. Biopsy shows a giant cell rich lesion. Now, what will you do? There is a giant cell rich lesion with the same X-ray. Anybody? Volunteer? Want to do, I've written the plans. Extended curettage, denosumab followed by extended curettage, resect and arthrodesis, resect and tumor prosthesis. Anybody?
I think
Yes.
we have to do an extended curettage in this case. That will be good enough. If it fails, then we can think of other possibilities. First choice will be extended curettage.
Okay, sir. So I just wanted to highlight here is, it's not giant cell tumor of the bone. It's giant cell rich lesion. So this is what happens, one of the mistakes, that if you see giant cell rich lesion, don't assume it to be a giant cell tumor of bone, because a giant cell rich lesion may have many differentials, both benign and malignant. So this is very, very important to read in between the lines. And it has happened multiple times that curettage has been done assuming that it is a giant cell tumor of the bone, and it turned out to be a giant cell rich osteosarcoma. So unless your pathologist has clearly, categorically written that it is a giant cell tumor of bone, please ask them to recheck it what it is exactly. So it was reviewed and it was giant cell tumor of the bone. So now we come, what's the plan now? Again, to the same.
I think extended curettage should be the first plan.
Okay, sir said extended curettage. Dr. Porter, your opinion, ma'am?
See, I'm not a surgeon,
True.
but to begin with, I tell you, we categorize giant cell into 3 categories. The first category, where a surgeon is confident taking the disease out thoroughly. The second is taking out with morbidity or with residual left. And the third is where you categorize the patient cannot be resected upon. So for this very lesion, I want to discuss this case with my surgeon, and second, very important, with my pathologist. Now, my pathologist will guide me depending upon the Campanaki grading system
yes.
that we had. What is the nature of the cells? You just cannot comment that this is a giant cell. Now, what was the demarcation of the cortex? What was the level of your giant cell? There was a prominent of stromal cell as well? And depending upon, was the borderline, it was a cortical destruction or there was extraosseous extension. So accordingly, I divide my cells into grade 1, grade 2, and grade 3. So this is very important as an oncologist I'd like to see. And the second thing, I'd like to have words with my operating surgeon, because this will guide me. If had I been dealing with grade 1 or grade 2 tumor, perhaps I will allow you to do a curettage if you are very much sure that I can do it. If not, grade 3, I'll go for a resection. Or if you see, madam, it's a borderline, I can allow you to go with the denosumab, couple of 6 months course, whatever you feel like giving, and then I'll replan my surgery. But then there's a disadvantage of using denosumab as well. So probably when my later part of the question that will take it, why shouldn't we use denosumab upfront before going for surgery, and why to go for upfront surgery? This is again a controversial issue. If you want to take it right now, we can have a discussion right now also.
Yes, sure, ma'am. But before that, one personal comment. Do you discuss a lot with Amulya sir, his orthopedic surgeon?
I'm a medical oncologist. I don't deal with giant cell very much until and unless yesterday you gave me a case where the giant cell had a transformation into osteosarcoma. Then my case, my role started. So being personal, I'm a totally medical oncologist. I don't deal with Amulya sir regarding any bone tumor.
So this is very, very important. Like whether the patient goes to medical, radiation or surgeon, we all should sit and discuss what it is exactly. And I think we'll quickly finish. Okay. So we need to grade it like Campanachi grading, which is a radiological grading 1, 2, 3. 1 is bone is completely intact. 2 is when there is some expansion but no cortical breach. And 3 is where you have an extra osseous soft tissue component. So in this case, like we were discussing extended curettage denosumab, how many people have given denosumab in giant cell tumors treatment? Sir, your reason indication for denosumab? Not in this case, but just in any case. Mike, please.
The tumor has fallen back to 1 stage down, and we were more confident and more easy to resect the tumor.
So
for
to
curettage.
facilitate your surgery,
Yeah.
shrink the tumor size. Anybody else? Any comments? Okay.
So I can make a comment again.
Yes.
So the data suggests that if you have the patient is in very pain or distress, 90%, more than 90% of the patient had a symptomatic relief, even if the patient could have taken for an upsell surgery. 48% of the patient had a good resection. I mean, a planned surgery with a very perfect margin, what was desired could be performed in 48% of the patient whom we give neoadjuvant denosumab, and 38% of the patient, they had surgeries with lesser morbidity. So this is the essence of using denosumab, but at the cost of more of a recurrences rate as compared had we done curettage upfront. So this is the guidelines with this.
Right, ma'am. So you have almost summarized.
Can I
the
add
whole-
one point? In this case, definitely we can go ahead with extended. Had it gone towards the plate, the lower plate, probably that was one of the reasons when you couldn't have taken off the entire thing and the margin positivity chance was more. Probably those cases you could have used it.
Yes, so role of denosumab is like it depends upon the type of the lesion that we see. So do we give denosumab in all the cases? Or I have few questions related to denosumab, which I think every time when we see a case of GCT, orthopedic surgeons think about it. Like, is it indicated in all cases? Dr. Porter, any comments on denosumab in GCT?
I think it was used a lot 5 years to 10 years ago, and more recently, as longer term reports have come out, there is more caution over its use. But the direct indications and recommendations are still being worked out. Therefore, individual surgeon and team choice have a major role to play.
So one thing is clear about denosumab, that once there is a large tumor, you want to facilitate your surgery, whether it is a curettage or resection, it will cause a lot of fibrosis, decrease neovascularization, increases ossification. So it shrinks the tumor size and helps you facilitate your surgery. Now very clearly said, like initially when the role started, so in India it was approved for use in GCT in 2013, and that time I had done a thesis on this, and somewhere I had a study of around 150 or 65 patients. So we realized that initially we were very hopeful about denosumab, that it is going to shrink the tumor, facilitate the surgery, but we realized in cases where we are doing curettage, after denosumab, the initial results were quite good, but later on they had a very high recurrence rates. Vis-a-vis cases which were very big, where we wanted to resect it, it has really proven a very good drug because it can shrink the tumor size, make you form a good ossified margin on which you can resect the tumor well, and the recurrence rates are also not high in those cases. So now the current indication is where the tumor is very large, you want to reduce the vascularity and then facilitate your surgery. So probably, sir, in grade 2, Campanachi grade 2, which are expanded bones and there is no extraosseous breach, it may not help much. But yes, grade 3, where the tumor has perforated the margins, it has come out, it will help in shrinking, and then you can do a proper curettage or resection in those cases. Okay, so role before and after surgery. Anybody for adjuvant after surgery, role of denosumab? If you have operated a case, a curettage, do you want to give denosumab later on? Any comments from our audience? I know our team is not orthopedic, Dr. Manisha, Dr. Pritanjali, but yes.
I don't think so. There is any role, except in few cases which in which the pain persists. Probably one of the indications you can use it, but there is no absolute indication in that case.
Okay. So if we look at the mechanism of denosumab, so you know this prevents the formation of immature to mature osteoclast, and that's why it has a static effect. It's not sidal for the drug. So if you have any tumor left, the best part of tumor clearance is that you need to surgically remove the tumor completely. That is the best mechanism to prevent a recurrence. Giving denosumab to prevent recurrence doesn't make sense because the day you will stop denosumab, it will again come back. So it takes hardly 6 to 8 weeks when the effect is weaned off, and then the tumor will recur again. So it has no post-op adjuvant role, except I would say some situations where it is inoperable disease, like you're in spine, pelvis, very large tumors, where surgery is not feasible. In those situations, you may think of it. And this is the dose that is given, 120 milligram with a loading dose, 1714, and then at monthly intervals. So this was some of the papers that was from Tata before. Just to quickly. So we see here, this was such a case where there was a large lytic lesion. Primarily, this was a case for resection, but we started giving denosumab to convert this into curatable disease, and we were able to achieve it after 6 doses. And you see how the tumor behaves. This all becomes quite fleshy. If you operate primarily upfront a giant cell tumor, there is granulation tissue, but after denosumab, it becomes quite fleshy. Even the bone becomes very hard. But at the same time, even the abnormal bone may become so hard like a normal bone, and you may not be able to remove the abnormal bone completely. So that's why the recurrence rates were shown to be on a higher side if you are converting a case from resection to curettage. So in these situations, be very cautious about the use of denosumab. You are going to leave behind the tumor inside with a higher recurrence rate. So these are the papers why we don't give denosumab on a long-term permanent solution, because disease recurs, and sporadic cases where malignant transformation has been reported. So apart from, ma'am, denosumab, apart from role in giant cell tumor, any other cases where you give denosumab in onco or, yes?
Oh, we have a list of indications where you give denosumab. So the list is both for benign and malignant conditions. The benign condition, I think most of us be aware of. So suppose if the patient is on long duration of steroids, or we talked about the parathormones, or the patient, on antihypertensive drugs, or the mood elevator. There are a lot of list of drugs where we calculate the fracture risk associated stratification, which puts on you the platform where the fracture can happen, and we need to use denosumab. Otherwise, for all malignant cases where you have a skeletal metastasis and where there are chances of skeletal related events to happen, to reduce that, I have to use for invariably in all cases, you have breast cancer, prostate cancer, renal cancer, thyroid cancer. So it's like every day, not less than 100 patients in my hospital, either zoledronate because of the cost or denosumab, the patients are ongoing. And definitely for osteoporosis, though this is not my domain, yes, you have to take help of Dr. Amulya here, where you need to have, we have to give these bone modifying agents. So again, that is a nice guideline where you categorize your patient, whether she's a low risk or a high risk for osteoporosis. So for very high risk, apart from denosumab, we have more drugs to be added upon as an adjunct to denosumab or zoledronic acid, where we have to protect your bone health. So there are so many other indications as well. And depending upon the FRAX risk scoring, how frequently I need to give, that we need to calculate.
Pritanjali ma'am, do you use denosumab or bisphosphonates in your patients who are on radiation for fracture prevention?
So yes, of course, we are using for fracture prevention, especially in bone metastatic patients, and we are giving radiation to them for the bony pain, and as well as the radiation helps in ossifying the bony lesions. And especially for giant cell tumors, if we take it that way, then we actually use radiation for maybe recurrent tumors, giant cell tumors that are not.
So
of
that
course
is my next
accessible.
question.
Okay.
So where do you give radiation in giant cell tumor of the bone?
So as I said, for recurrent cases, we can give radiation to the area, or for those patients which are unresectable upfront, especially if it be from the vertebral region or the sacral region or the skull base region. So those areas are unresectable, and then we offer those patients radiation. It can be given to a dose of about 50 to 60 gray, which would take care of the tumor growth per se, and settle down the tumor for a long time. But there are, of course, chances of recurrence for the tumor as well.
Right, ma'am. So if just to summarize for the orthopedic surgeons here, giant cell tumor as such is a surgical disease. We use different drugs like bisphosphonates or rank ligand inhibitor denosumab to facilitate your surgery. But in certain situations, like if you have a tumor in spine or pelvis which is inoperable, recurrent, multiple recurrence, it's not possible to clear up. You have different modalities on a step ladder pattern that you use to prevent a recurrence and to cure the disease. So like ma'am said, radiation therapy is one of them, which we reserve it. If everything is not responding, this is the modality that you can use to treat the patient. Ma'am, any fear factor or anything you have in using radiation in these cases?
Fear factor means there are chances of it converting into sarcomas.
So
that
that
is one factor that we have to take into
So
consideration.
that is the reason why reserve radiation as a last resort, because GCTs are as such benign. And if we expose them to radiation in the long term, so radiation-induced sarcomatous transformation is one of the potential risks, although I think it is quite low nowadays with the machines that we use, the recent Linux and all.
Chances of conversion is about 1.5 to 6% in certain cases.
Right. So it was high with the initial cobalt machines that we used, because if we see the patients who had received radiation before, we see a lot of patients, say up to 10% who have after 10 years, 15 years, development of secondary sarcomas there. So yes, one more modality that is used is serial angioembolization, where we embolize the feeding vessels, the arterial vessels, along with denosumab to ossify the mass, and serial angioembolization may be also a definitive treatment in these cases. And to summarize your surgical, if surgery is not possible, you start with denosumab, serial angioembolization if that is not possible. Radiation, keep it as a last resort to control the disease. So if we talk about broad overview of management of GCT. So Dr. Daniel, so what are the two types of surgeries that you do in giant cell tumor, like in this case of distal femur? So like, I mean,
you mentioned in your summary there, either extensive curettage and filling the defect, or a resection and reconstruction.
right. So two types of surgeries. Either you do an intralesional surgery like curettage, or you do resection. So which one would you favor mostly?
Well, we would like to preserve the knee joint if possible, and as a general rule, in a younger person, we would attempt a curettage and see what happened.
So broadly, if you see, we always want the procedure to be less morbid. So we preserve the native joint, because if you resect the joint, you have to use some mega prosthesis, and over the time, at some point of time, you need to revise it again. So if you can preserve the joint, that is the best possible solution. So if we look at,
So just I can add upon, Vivek.
yes ma'am.
Yes, definitely we want to do a curettage because we want to preserve the joint. We have to have a less morbid surgery because we want to give a quality of life. But again, what I said earlier, depending upon the Campanella scale of your grading system, if it's a grade 3 tumor and you've just gone for a curettage, your chances of recurrences are very high, 16% to the tune of 60%. So in that very cases, you have to have your resection done.
I
So
agree,
that
ma'am.
is also very, very important when you decide what modality of surgery are you going to embark on your patient upon.
Yes, totally agree that if the recurrence risks are high, if there is an intra-articular fracture, we need to discuss with the patient whether to go for a joint preserving surgery or resection. Usually, up to if 3 cortexes is gone or the intra-articular fracture is there, mostly these are the cases where we need to resect the bone and do a replacement for a mobile joint or an orthodesis for a fixed joint. So now coming back to the case, this was there. So the MRI showed us, yes, there was a cortical breach, some soft tissue component. And for the lack of time, I will quickly just go through this case. So how we plan a curettage is also something we should know, because it is no more curettage, it's extended curettage in giant cell tumors. So first we need to make a bone window, and whatever is the longitudinal extent of the tumor, you need to open it completely. So don't make a small window and try to curate it. Open it completely. Then you need to have high-speed burr as a tool. So this burr, at least minimum 40 to 50,000 RPM. This helps in clearing the tumor cells. You clean it completely. Then you have to use other adjuvants. This is a mechanical adjuvant. Other adjuvants are chemical or thermal adjuvants, by which you clean this cavity completely. Now you can see how this looks like after this extended curettage. Now we have different chemicals that are used: hydrogen peroxide, phenol, liquid nitrogen, etc. And I prefer hydrogen peroxide mostly, or phenol in certain cases. But most important, I think the message is that a complete extended curettage with mechanical burring is the most important tool to prevent recurrence. So the current studies which are coming out, they have shown with extended curettage the recurrence risk somewhere between 10 to 15%, even in grade 3 Campanella, if you choose the patients correctly. If there's intra-articular fracture, gross soft tissue mass, it's better to resect it.
Dr. Vivek, in this extended curettage, once you are taking off the extended portion, do you often send margins for, not frozen, for histopathology later on? So you need to be very sure whether the margins are negative. So I think it should be leveled separately and sent.
So sir, in benign tumors like this where we do extended curettage, it's an intralesional surgery overall. So what I rely on is not on the margins, but what I rely on is the pre-operative calculation of how much part of the bone is involved based on X-ray and MRI. And intraoperatively, I confirm my clearance with the fluoroscopy machine. So pre-operatively, whatever part of the tumor was seen, my extended curettage should be beyond that area. So this is the best way to achieve.
Thank you. For benign lesions, we can't expect that every cell is dead, but has been damaged, and that the immune response of healing, as well as all the work that you do, is sufficient to eventually kill every cell.
Yes, sir. So once you have done the extended curettage, the next question always comes to the orthopedic mind is how to reconstruct, whether to use bone graft, whether to use bone cement, whether to use plates or not, or just leave the cavity. So any comments from the audience? Sir, your choice, sir, in GCT, bone graft, bone cement? Bone grafts. Sir, any other comments from seniors? So I think both the options are quite valid, and it depends upon age of the patient, the cavity size. If it's a very big cavity, we may not have adequate bone grafts in those situations. Bone cement is very handy. Amount of the bone that is lost. So I think we have already shooting the time. So I will quickly summarize this case. So we have both the options, and both the options are correct with advantages and disadvantages of each. Bone cement has, I personally use bone cement in all my patients except when the cavity is small and it's a young patient. It gives immediate stability. It has exothermic effect and cytotoxic effect and gives adjuvant role on tumor cells killing. Disadvantage, if I have to do a revision, it's very tricky. Majority we need to resect it on the second time. The biggest advantage of bone grafts is if there is a recurrence in future, you can always do a recurettage. That is possible.
Dr. Vivek, would you like to highlight here irradiated bone graft or it's available in the bone bank?
So normally, from bone bank, it's you need to procure it from some centers like TMH or AIMS. So I use autologous bone grafts from iliac crest or fibula.
Yeah,
to
but
fill.
if the cavity is large enough, it will be difficult to fill with the bone graft.
So that's why my personal choice is bone cement. I prefer bone cement in 99% of my
So
cases.
you won't ask for a bone bank to supplement you with this?
So I'm very much comfortable with bone cement. One of the controversies before was that using a bone cement may lead to early degenerative arthritis, but that also has proven wrong. So initially that tradition was probably 25 years back that after putting in bone cement, they used to remove it and put bone grafts in second stage to prevent degeneration. But it has been shown that a well-packed cement or well-packed bone graft, if it is well-packed, it will not lead to early arthritis. The problem happens when the articular surface is not
Loose.
rigidly fixed and it's loose, then it leads to degeneration. So this is what I did, bone cement and plating. And this is sandwich technique. When your subchondral bone is very thin, hardly 1 millimeter, or you have reached up to the cartilage, it's important that you some morselize and put some bone grafts so that you can put a bone cement underneath to pack it. Other case scenarios in these type of situations in giant cell tumor recurrent case, we need to resect them, use omega prosthesis, and the most common site is around the knee in giant cell tumors where we can use, like I said, a fixed procedure like arthrodesis. Biological with turnoplasty, if there is tumor in distal femur, you can resect and you can do a turnoplasty by splitting the tibia, taking it up, fusing it. Or when there is infective case like this where you need to do a temporary spacer, you can use nail cement spacers. So I think with this, we finish this panel discussion and we can discuss more later on. Thank you, everyone.